Thank you so much for having me here. It's great to be here in D.C. with such a wonderful weekend. I hope many of you are participating in the race, and hopefully can teach you a few things here today. Many of you are probably already experts in ovarian cancer, fortunately or unfortunately. And I hope to provide a little bit of basis for everybody. It's not a real technical talk. You have some more technical talks coming up, and I'll be referring to some of those as we go through this. We do hope to kind of understand the definition of recurrent ovarian cancer. And we'd say, well, that's pretty obvious. That's when the cancer comes back. But we'll talk a little bit about what it means when the CM25 starts going up, what it means when we see something on a scan, and how that impacts whether we should do anything. When do we act? When do we wait? These are really hard decisions. And then we'll discuss some of the treatment options we have available, be that surgery, medicines, chemotherapies, pills. All these things are important. I'm not going to talk a lot about the survivorship component because we have other talks down the road that will talk a little bit about that, but I do want to stress that we're not just treating the cancer, we're treating the patient. And there was many other things that are a part of that. And symptom management is key. I was curious, how many people keep a log of how they're feeling, what their CM25 is doing? Perfect. I mean, I think it's so important to be actively involved, especially for a disease like ovarian cancer that hopefully will last for decades, longer. I have many patients now that are in their 12th, 14th year of fighting this disease, and I say, well, let's go back to topotecan, and then she'll pull out her logbook and say, well, I had that in 03, 09, and I was thinking about, again, the last time I felt a little fatigued, you dropped my dose. It's so nice to have all that. You'd think with our electronic medical records, we as physicians would have that all at our fingertips, but we don't. And I think that being actively engaged in this process is very, very important to really help minimize your symptoms, because there's a lot we can do, but we need that information to help manage this. So unfortunately, recurrent ovarian cancer is all too common. If we look for patients that have a complete response to their upfront surgery, complete response to their chemotherapy, as in all the disease has gone away, if we take those patients back to surgery following that, about a third of patients will have disease seen. So even when we think it's all gone, it's not all gone. And then even if we don't see any cancer, over half those patients will eventually recur. So when we look at it for patients with advanced stage ovarian cancer, about 80% of the time the cancer's likely to come back. And having had the discussion already about options, do we restart chemotherapy? Do we try a clinical trial? Do we use radiation? These are many different things that we'll be discussing. Well, how do we determine if somebody's actually had their cancer come back? Symptoms are very important. I think that's, again, why it's important to keep a log or some type of record about how I've been feeling and what are those symptoms. And I know the foundation has done a lot to try to get the word out for symptoms of ovarian cancer, so we do have the changes in our bowel or bladder habits, abdominal bloating, changes in our diet. All these things are important as we think about symptoms of the cancer coming back. We'll use a physical exam. I'm sorry, I'm kind of blocking this table over here. I know they're trying to work around me. Blood tests. I know many of you know a lot about CA-125. Often we have an entire talk just on CA-125. It's such a controversial subject. But I imagine many of you know quite a bit about it. And then imaging. And we'll talk that there's really no standard way to follow patients. In fact, our SGO Society recently came out talking about choosing wisely, which I don't know if many of you know about the Choosing Wisely campaign. It's try to minimize things that really haven't been shown to be a big benefit. And one of those things is routine scanning for asymptomatic patients with ovarian cancer. So doing a CAT scan just because we can do a CAT scan hasn't shown to make a difference. So we're trying to discourage use of routine scanning. And especially that's in patients that CM25 is a marker. But we'll talk a little more about that. There is really no standard way to follow, but we do recommend if you're going to get a physical exam, the rectovaginal exam seems to be important. Why would that be? Well, ovarian cancer does tend to come back deep in the pelvis, and oftentimes we can feel that as one of the first signs of the cancer coming back. So what should we do if we have abnormal findings? And this is a kind of a busy diagram, but talks a little bit about, I have a patient with abnormal symptoms, abnormal exam, or a bad blood test. What does that do? Often that means a discussion, and usually we proceed then with imaging if it makes sense to do so. That imaging may be equivocal. We may not know what it means. So what do we do then? We can either wait and see if things change over time. That can be important. We could consider further imaging with something like a PET scan. Now, PET scans are really quite a fantastic scan. So as a physician, from an intellectual standpoint, as much information as possible is always really great to have when we're making decisions. And as a patient, I'm sure you'd like to have the best of the best. But in reality, things like PET scans may not really change things. They may show us a little bit, but they also may show too much. Sometimes there's a lot of false positive with PET scans. So we can add up with increased worry, increased problems. So for people that are out there saying, God, you got to get your PET scan, or if you're on a website where they said, insist on the PET scan, there's some downsides of all this. That being said, sometimes it's utilized, and I order them myself, especially if I'm trying to decide about if surgery is important for the management of recurrent ovarian cancer. So sometimes a PET scan will help us to say, yes, I could go in and likely get all that out. This is just an example of a PET scan. PET scans are radio-labeled or radioactive sugar that goes in and actually is a very good reporter for areas of rapidly dividing cells. And so areas of inflammation, diverticulitis, those type of things will also show elevated PET scan activity. So it's not perfect. And really our goals of care have to be established. If you come into my office, you have a rising CM25 and you feel perfect, you're eating well, doing fine, it's really hard to make you feel better when you have no symptoms. So I want to make sure we're not causing harm by putting somebody on therapy that feels great doing well. Because really our goal needs to be to improve symptoms, prolong symptom-free survival, so keep you feeling good as long as we can, and optimize your quality of life. Now, Dr. Herzog later today will be talking a little bit about survivorship and quality of life, and really expanding on what's important from a patient's perspective. So I'm going to defer a little bit to that talk later this afternoon. And really our goal is to live as long as we can with the best quality of life. So how do we make all these choices? And I know this is a busy diagram that talks about surgery, radiation, chemotherapy, palliative care, hospice, and then the choices of different therapies, the timing of all these things. And this is where individualized medicine is very important. Now, Dr. Beer is going to be talking to you about personalized medicine from a molecular standpoint, but there's also individualized medicine based on knowing the patient, knowing your goals, knowing when your daughter's getting married, knowing when you want to have hair, when's that important to you, when's it not, how the neuropathy is. Are you a pianist? Do you do a lot of knitting to where neuropathy is really damaging to your quality of life? All these things are very important to have that doctor-patient relationship or nurse coordinator-patient relationship that helps us decide what is the best therapy. So if there is things that are impacting your life, it's important to let us know, because all these things can impact what we choose in our discussions for the best therapy. And again, these goals come into play whether we should say, I feel fine, my marker's only coming up slowly, I only have a little bit of cancer, there's no signs of obstruction, I want to travel to Europe for the next 3 months. Sounds like a great time for observation. Let's just follow this. It looks like we have time. The tricky part of all this is we want to intervene before there's bad symptoms, before there's bowel blockage, before there's other things. So observation, although it makes sense, we want to know when to act so we can keep people asymptomatic. And that's a tricky part about this. Surgery, when should I undergo repeat surgery? And I'll talk a little bit more about that. When do we use similar chemotherapy, different chemotherapy? And a lot of this has to do with what our goals are and what we're trying to achieve. We all want to have you live as long as we can with the best quality of life, and that needs to remain paramount. Again, just showing some recurrent disease on imaging, where you can see these are disease that's recurred in just lymph nodes. And sometimes that's actually a better finding because it's less likely to cause symptoms. It also makes it tricky to know when to act with something such as this. Why would we do surgery again? We had their upfront surgery, you got it all out, and it came back anyway. Why should I go through surgery again? There's a wide variety. Many of us are like, well, if you can cut it out, get it out of me. Other people are like, well, that surgery was so hard on me and it didn't cure me anyway. Why should I do that again? One of the things we know is big, large tumors sometimes don't respond well to chemotherapy. The inside of the tumor is not getting the chemotherapy delivered to it very well. So in fact, maybe taking out a tumor may make sense. What we've learned over time is if we are going to do repeat surgery, that goal of surgery really needs to be removing all of the visible disease. Going in and taking out a little of it probably is not going to be helpful and probably only harmful. So in those settings, further imaging, thinking about things like PET scans to try to help really gauge who's going to benefit from repeat surgery makes sense. The other goals of surgery, if somebody has a blockage, perhaps relieving that blockage to avoid some of the bowel or urinary complaints, and allowing us to maintain our nutritional status. So if there is something where the surgery can help, hopefully that would be one of the appropriate goals. What about going back in and taking out all the disease? There are some features that are associated with actually that seeming to be beneficial. If your disease has been away longer than a year, you had a complete response to your initial therapy, you have a good performance status, as in you could tolerate the surgery well, no really large tumors, and probably likely to need additional chemotherapy. It doesn't make a lot of sense to go in and do surgery if we're not going to do further treatments afterwards. And really our ideal situation is if the disease is localized and we can get it all out. That really needs to be our goal. Dr. Chi at Memorial Sloan Kettering in New York put together this table. I would say they're a little more aggressive about offering repeat surgery there than most places. But again, it's all kind of subject to further research, and Dr. Chi's done a great job in publishing the results. And this is the discussion based on how long it took your disease to come back, or disease-free interval, 6 to 12 months, 12 to 30 months, greater than 30 months, whether there's a single site recurrence. Basically, in all those scenarios, he would suggest secondary cytoreductive surgery, so going back in and taking that out. If there's multi-sites, really only if it's been over a year would they consider doing that. And carcinomatosis is where you get this fine little spread of tumor throughout many of the surfaces, and really not unless it's been almost 2 to 3 years would you consider going back in and reoperating in that situation, because it's just so difficult to get all that disease out. We do have randomized trials looking at this. Dr. Coleman, who's typically been a big champion of this meeting and often gives talks, actually not talking today, but he is the study chair for this important study that's looking at the role of surgery for patients with recurrent ovarian cancer. Now, as I mentioned to you, many of us already think we know the answer to this. And it's often a personal approach that, oh yeah, I definitely want surgery. Or I'll talk to patients, no way I want surgery. So sometimes it's hard to sell a randomized trial. So this has taken quite a while to get the answer. TFI is a treatment-free interval. So we've been off chemotherapy for greater than 6 months. I'm sorry, I should define some of those things. So the patients had recurrent cancer or fallopian tube cancer or primary peritoneal cancer. They've been off treatment for greater than 6 months. Are they a surgical candidate? We're randomizing them to yes or no, and then getting chemotherapy. So what are our chemotherapy options? Choosing chemotherapy. As I mentioned, patient factors, very important, where we actually would keep track of how you're feeling, how you're doing, what your neuropathy is like, hopefully, or not having neuropathy. And then the drugs that we have to choose, we do have a large list, and I'll be going through that list about the options we have, and we would try to tailor those features to minimize the previous toxicity you may have already suffered. And then try to use tumor factors and optimize this interaction to where, let me give you an example. Some of our chemotherapies take a while to work. Some of them act rather quickly. And if somebody comes in and showing signs of a bowel blockage, really feeling poorly, and it came on quickly, I probably want to choose a treatment that's going to act rather quickly, and that may be sacrificing some of the other benefits. There are drugs like liposomal doxorubicin that take a while to work, but they also cause very little side effects. So those are some of the different personalized medicine types things we may do to try to help maximize your survival and maximize quality of life. So we really want to limit additional toxicity. So if you're already suffering from numb hands and feet, avoid making that worse. Trying to use a convenient schedule. Now some of the drugs we can use are on an every 4-week basis. It's especially helpful for people that have to travel long distances or summertime where they want to spend time at their lake house, whatever it may be. Convenience and schedule are important, and we do have some flexibility. Obviously, chance of response is important, but really disease control, symptom control is probably most important. And then, again, avoiding those unwanted side effects based on timing. Now, sometimes we're stuck. This is what works. This is what we need to try to do. And it may mean we have to do sacrifice schedule to help control toxicity. Sometimes if we give a drug weekly, we can minimize the amount of numbness in the hands and feet, but still maximize the chance of the drug working. So there is some evidence of that. You may hear a lot, or those of you that are, like I said, experts in the field, you read a lot about platinum sensitivity, platinum resistance. And I wanted to touch a little bit on just defining what this means. And basically, if with your first diagnosis of ovarian cancer, you get treated with chemotherapy with usually carboplatin or cisplatin, and either if the disease gets worse or the disease comes back within 6 months, we consider that platinum resistant. And which typically means using those drugs again or using platinum again is unlikely to work very well. Secondary platinum resistance, you had at least a partial response at the second line setting, and then the disease came back within 6 months. But I don't want to focus too much on that. I think it's a little easier to see this in graphic format, where we consider somebody resistant if that disease comes back in that first 6-month time interval. Some people also use the term refractory. That's if the disease comes back in that first 3 months or it grows while on chemotherapy. Really unlikely to see that. Now, why is this important? Well, this actually gives us a sense. If the cancer came back 2 years later, we're very likely to use the same regimen or at least the platinum again because it has a very high rate of likely being successful in causing the disease to shrink. As I mentioned, we have a whole list of different agents that are available to us. This is through the National Comprehensive Cancer Network's preferred agent list for patients with recurrent ovarian cancer. As you see on here, and I know it's a little small and hopefully shows up in your booklet okay. Whoops. That's worse. What's that? Oh, even smaller book. Great. Oh, perfect. Sorry about that. So the different lists of drugs are available online too through the nccn.org. But really looking at carboplatin paclitaxel, either given weekly or with some of the different agents. And many of these other agents are out there and available, and kind of the laundry list of things we're choosing between. I don't want to spend too much time on the data about all this, but most of these regimens have been evaluated in randomized trials, where half the women were given one regimen, half given the other. They all have fancy names like ICON, AGEO, Calypso, Oceans, and they're just looking at different drug combinations and showing that and sometimes we'll use 2 medications or 2 drugs together, just like upfront chemotherapy. We'll sometimes do that in recurrence. And this is some of the evidence to support using 2 drugs. And often what we'll see is there's improved response, as in the disease will shrink more, and the disease may actually stay away longer. It hasn't always seemed to impact overall survival. So sometimes we may choose to use 2 drugs together, or we may choose to use one after the other and likely get similar effects. And that, so sometimes that's always difficult to interpret if you say, well, he wants to use, or she wants to use drug A, but my other doctor that I went and got a second opinion says he wants to use 2 drugs. And that's always difficult because a lot of that decision making has to do with managing toxicity and hopefully to control the disease without causing undue toxicity. I just wanted to focus on one of the trials. I think you've heard a lot about bevacizumab or Avastin. It's quite an active drug in ovarian cancer. It has a rather unique side effect profile in that most patients have very little side effects from it. We do have some high blood pressure, sometimes some kidney damage, a very worrisome factor in that sometimes can cause perforation in the intestines. The problem is we don't really know how best to use it at this point. Whether it should be given with upfront chemotherapy, whether given once the disease has fully gone away is what we call maintenance therapy, or given at time of recurrence. And at time of recurrence, should it be given with other drugs or by itself? All these things remain unanswered now, 10 to 15 years in development in ovarian cancer. But there are several trials, one's called Oceans, one's called Aurelia, that are looking at adding bevacizumab to regular chemotherapy and seeing it actually working better. And this is just what are called survival curves for the disease coming back. And you see there's about 50% prolongation of the disease not coming back by adding in the bevacizumab. Now, that same story exists. Well, what if you just give the bevacizumab after the chemotherapy? Does that do the same thing? And that's what many people have speculated because the overall survival between these 2 arms is about the same. So whether you give it with the chemotherapy or after the chemotherapy, we still don't know all the answers. Should we do chemotherapy in the recurrent setting? Unfortunately, most of the time with ovarian cancer, the disease is eventually going to take your life. Now, every time I say that, most people, there will be survivors in the audience say, you know what, I beat it. And there are exceptions to that. But for the most time, we're dealing with a lifelong disease that we need to learn to control. So how much effort do we go through? What types of therapies do we go through? Again, a personal decision, and really it requires you to be very active in discussing this with your physician. What you want to continue to go through, when you want to say, I've had enough of this, or I need to do a break, or I need to have something changed, is all important. I'm going to touch briefly on assay-driven therapy. Many of you will read about the different assays that are out there and available. Many different cancer centers now are also developing a gene profiling of cancers. Unfortunately, for as many years as we've been looking at these assays, we're still not sure about how much they help. We've known for a long time that if somebody has a bladder infection, we can culture that bacteria, we can expose that bacteria to a bunch of different antibiotics, and see which one works. Well, we've tried that with cancer with variable degrees of success. And in fact, there is some hints that some of the assays may help, and to try to individualize, well, who needs drug A versus who would benefit from drug B versus drug C. And I really can't tell you strongly that we should be using these assays, but they are continuing to be developed over time. And so if there's opportunity to participate in a research trial involving this, I would strongly encourage patients to participate. There's another list that Dr. Bira will be probably expanding on, all the different targets, or which are hopefully Achilles' heel of ovarian cancer, are out there and things that are being developed to treat ovarian cancer. So there's definitely reason for hope. We have many different things. I know Dr. Fowler talked to you about the different types of ovarian cancer. So we have unique therapies that may be different for different varieties of cancer. I'm just going to talk real briefly on radiation therapy. We know certain cancers, like the clear cell cancers, the endometrioid cancers, tend to recur often just in one spot. So we might go back in and resect that. We might even think about using radiation in that setting to where we really can sterilize one area. Unfortunately, radiation only works where it's given, in one spot. It also tends to damage the surrounding areas. So it can damage things like bone marrow and make people less able to tolerate chemotherapy down the road. So we don't use radiation a lot in ovarian cancer. Our colleagues to the north in Canada tend to use it a lot. But we do see quite good response with radiation. So there may be a role, and we don't want to I think that that should be something that shouldn't be done because there's definitely a role for it in certain circumstances. Just briefly on some of the complications, and I think that you'll be hearing a little bit more today about fatigue, depression, and appetite as part of survivorship. Again, I think it's very important for you to report to your doctor when fatigue is getting to be too much. I would suggest that everybody should be in some type of exercise program if possible. There's fairly good data from other cancers that exercise is important in maintaining quality of life and probably does have an impact on depression and mood changes. Many of the cancer centers have a very active psychosocial program with psychology and aggressively addressing things like depression, anxiety, and stress. And I can't underestimate the impact that has of just asking our patients how's their depression, how's their anxiety, because it's such a big part of coping with obviously a life-threatening disease that it really needs to be addressed and managed. And we do have a lot of therapies available for patients to address these things. Anorexia, there's medications, there's supplements, there's many things we can do to help avoid that loss of appetite. I want to talk about a few things from a surgical standpoint. Pleural effusions, which is fluid building up on the lung, ascites, which is fluid in the abdomen, blood clots, obstructions. Many of these things we can address directly by utilizing small, minimally invasive interventions, and this is what's called a Pleurex tube, which is a small little tube that goes into the lung, very discreet. I mean, nobody wants to have a tube, but it really has been quite nice for allowing patients to be at home, draining fluid off the lung, not having to be in and out of the hospital, and really managing their symptoms of ovarian cancer. Patients with blood clots, we sometimes can use a screen called an IVC filter to help minimize the chance of those blood clots going to the lung. The gastrostomy tube, or the G tube, is something that we actually use quite a bit. And many patients fear, or they've read a lot about, dying of ovarian cancer of a bowel obstruction. And that's how a lot of our patients have trouble late in the disease, is the bowel gets blocked. And we worry that that can be painful. And a small tube placed directly into the stomach helps decompress that gas and fluid from building up and minimizing symptoms. These tubes can be quite discreet. This is a tube placed directly in the stomach. Our interventional radiologists can help us place these through tiny, tiny incisions, and really brings out a lot of freedom for patients. So when they feel sick, they open the tube, drain out the fluid, not having nausea and vomiting. When they feel good, it can be capped off, eating, and sometimes even having some nutrition through such a tube. They're not ideal. I don't want to oversell it, but it certainly can allow people to really maintain quality of life much, much longer without it. So where do we go from here? Dr. Beer is going to talk to you a lot about research from the standpoint of individualized therapy and tumor genetics. I think we'll skip ahead a little bit in the interest of time, but I think that when we say personalized medicine, that doesn't always mean a biologic test, that doesn't always mean tumor profiling. That can mean talking to your patients about their goals, about their current status, and moving forward to try to come up with optimal therapies to really maximize quality of life. So with that, we'll give one last plug for clinical trials, because that's the only way we're going to get smarter, only way we're going to get better, only way we're going to help more people. So thank you so much.